Okay, so we are opening today with Dr. Hyman Scott. It's really exciting to be able to introduce him. Dr. Scott is the Clinical Research Medical Director at the Bridge HIV program for the San Francisco Department of Public Health and an Assistant Clinical Professor of Medicine at UCSF. He received his MD degree from Yale School of Medicine and completed internal medicine residency, chief residency, and infectious disease fellowship, as well as his postdoctoral research training at UCSF. He's got a particular interest in the epidemiology of HIV-related racial and ethnic disparities among MSM and interventions to reduce those disparities. Dr. Scott currently has a K23 award to develop and test mobile app-based combinations of HIV interventions in the setting of home HIV self-testing, STI self-collection, and pre-exposure prophylaxis uptake to optimize that among young Black and Latino MSM in the San Francisco Bay Area. It's really a pleasure and an honor to introduce Dr. Hyman Scott.
Good morning. Oh, good morning. That's better. I'm Hyman. I'm from San Francisco. Happy to talk about STI prevention today. So I'll just go ahead and get started. And I have no relevant financial relationships to disclose. This is the roadmap for where we wanted to go today. So I wanted to talk about trends in STIs, talk about some of the data for DoxyPEP, and then if we have time, depending on timing for today, might get into a little bit of discussion about the meningitis vaccines that are hopefully going to have some efficacy for gonorrhea prevention. All right, so STIs are getting worse. These are the data from CDC in 2022. Everything is going up except for chlamydia, where we've seen a slight decline in chlamydia. We're actually seeing locally that we're seeing more cases of gonorrhea in many of our sexual health clinics than chlamydia cases. And syphilis cases continue to rise. In particular, concern we've seen congenital syphilis, and with these large number of cases, we're just seeing more complications. So, you know, I have several patients who are now partially or fully blind from ocular syphilis, and so we're just seeing a lot of complications across the board. And where we've seen rates going up of chlamydia, you know, we saw the drop off in 2020, likely secondary to declines in testing, but we've seen this rise over time, going back to the 90s for chlamydia. And then for gonorrhea, we're seeing similar things. I like this slide for two reasons. One, it shows that we've seen this increase, and that also, I do a lot of PrEP work, and there's a concern that the rollout of PrEP has led to increasing STIs, but we've seen this rise well before we had PrEP widely available. But also that a lot of the test diagnoses are not happening in our STD clinics. They're actually happening in the clinics that you all are seeing patients. And so I think this is a testament to the testing that's happening across our clinical settings, where we're diagnosing and treating more STIs, in particular gonorrhea. And I think that this is essential for doxycycline for post-exposure prophylaxis. We cannot have this just in our STD clinics. We need to have this in the places where people are making diagnoses, which are the clinics in which you all work. So I wanted to switch now to talking about DoxyPEP. And so we'll start with an ARS question. So this is a similar case that we've had locally. So this is a 34-year-old cisgender man who's currently on oral PrEP since 2018. And he's had multiple bacterial STIs in the last 4 years, and then recently started on doxycycline PEP. He had a negative 3-site GC-CT NAT and RPR 2 months prior on part of his regular testing. And then he says a sexual partner texted him yesterday to report that he had been diagnosed with gonorrhea. He didn't know what site he had, and he reported that he was versed with this partner for oral and anal sex about 2 weeks ago. And he's been taking DoxyPEP within 24 hours as recommended by his provider with all of his sexual partners except for his husband. He has no allergies, so you're going to do 3-site NAT testing, but what else would you recommend? So would you recommend giving ceftriaxone 500 milligrams IM times 1? Would you do that with doxycycline as well for 7 days? Give no antibiotics while waiting the NAT test results, or either A or B with mycoplasma genitalium testing.
You know that it would be untrue. You know that I would be a liar if I was to say to you, girl, we couldn't get much higher. Come on, baby, light my fire. Come on, baby, light my fire. Try to set the night on.
Okay, give it a couple more seconds, and then we'll, I think you're slowing down in the responses. Great.
No time to wallow in the mire.
All right. So we'll go to the next slide. All right. So about a third of people would treat with ceftriaxone. About a third would wait. About a quarter would give ceftriaxone and doxy, and about 8% would do A or B or mycoplasma genitalium. I'm going to talk through a little bit of these data. I think if they are taking doxycycline within 24 hours, I'll show some of the data that, doxycycline in the clinical trials has had efficacy. I think post-CROI, I would do something different. I think some of our clinical implementation data, as a spoiler alert, has suggested that we might not be seeing the same level of efficacy in rollout that we saw in the clinical trials for gonorrhea. So I think before CROI, I would have waited and tested them, but I think post-CROI, I probably would have treated them based on the EpiTreat. All right, so what is the data that we have on doxycycline PEP? So this was a large trial, the DoxyPEP trial, which you probably have already seen. There were 2 cohorts of MSM and transgender women, a cohort that was living with HIV and a cohort that was taking HIV PrEP. So the inclusion criteria, which are on the left, are important because many of the guidelines are using these criteria to determine who should be offered DoxyPEP in jurisdictions that are coming out with guidelines. So it's essentially male sex at birth and having 1 STI in the last 12 months and condomless sex with at least 1 partner. So these are the data from the primary endpoints for the STI incidence per quarter in these 2 cohorts. You can see in the standard of care that they're seeing upwards of 30% STI incidence per quarter in those who are not on DoxyPEP, and that declined dramatically, 66% among those who are on PrEP and 62% among those living with HIV, for overall a 65% reduction across the cohorts. When you look at the sites, so these are the data that are evaluating sites, so gonorrhea, chlamydia, and then the lighter color is urethral, the middle color is pharyngeal, and the darker color is rectal only sites, and then the black, red, and are just if there's multiple sites. So what I wanted to highlight is that the majority of these cases are sort of pharyngeal or rectal sites. So that's where a lot of these diagnoses are being made, and that you're seeing a significant reduction across these sites. And then when you look at where the risk reduction is for each of these infections, for gonorrhea, you see a similar about 50% reduction for both the PrEP and the cohort of people living with HIV, a much higher efficacy for chlamydia among these 2 cohorts. And then for syphilis, likely because of small numbers, we didn't see a significant reduction in syphilis for people living with HIV. But if you look at the numbers, there are very few cases, even though these are pretty large cohorts. So the point estimates are similar, although it didn't reach statistical significance, in case that comes up in a question. There's a lot of questions about antimicrobial resistance, and I think that antimicrobial resistance is probably the main driver of some of the resistance to the rollout of doxycycline PEP. And so these are being studied in the different trials. So these are the data from DoxyPEP, where this was looking at culture data, and at baseline, there was pretty low levels of tetracycline resistance, and that there was some increase in the resistance in the DoxyPEP versus the standard arm. So it is something that I think is occurring. The implications and clinical impact of this, I think, is something that is not quite clear yet, but it is something that we sort of expect to be happening. So for Staph aureus colonization, they actually saw a 14% absolute decline among those on DoxyPEP, which was statistically significant. And so there's this balance between resistance and some of the changes in colonization that might occur. We also saw some resistance develop for Staph aureus and doxycycline, and this was, really the concern about these bystander bacteria that might develop resistance in the setting of rollout of doxycycline PEP. So these are the data that show that there was a 8% absolute increase in resistance that occurred in Staph aureus. So moving into what we found in CROI, which I think was really exciting, we had a lot of sexual health, STI data that were presented. So the DoxyPEP study, which I just talked about, had an open label extension, which showed that those who were in standard of care were switched to doxycycline PEP. And then you can see that as randomized, there was about a 31% incidence in the standard of care, and that declined to 17% in the open label extension. A lot of these cases are gonorrhea, as you can see, as we've seen increases, and very few chlamydia and syphilis cases in comparison. One of the things that came out of the OLE data, which I think raised a lot of questions, was what happened to sexual activity as you switched people from standard of care to doxycycline PEP. And so what you can see highlighted in the red box is that compared to the as randomized standard of care, the absolute number of sexual partners did increase. The absolute number of condomless and sort of sex acts per quarter increased, as well as receptive intercourse. So there was high coverage of these sexual acts. So you can see 81% of the sexual acts were covered by doxycycline PEP, but there does appear to be some likely risk compensation that was occurring as people were on DoxyPEP. How much this makes a difference, I think it'd be interesting, and be interested to hear what the audience thinks about some of these data. There's also some data on the gut microbiome. A lot of people are really concerned about the gut microbiome and doxycycline. So there was a poster that was presented that showed that there was minimal impact of doxycycline PEP on the gut microbiome, but that there was increased expression of resistance genes in the microbiome among those who are on DoxyPEP. So I think we're seeing that there's this increase in resistance that occurs with Staph aureus. We likely will see this with some gonorrhea cases, and then other bacteria that are in the gut as well. So this is one of the downsides for sure for doxycycline PEP, but I don't think it compensates for the amount of impact this can have. There was also an update from the DoxyVac study. So DoxyVac study was a study that was looking at doxycycline and the meninge-B vaccine for STI prevention. And they reported results in 2023, and then it came out with a very vague retraction of those results several months later. And so these were the updated results from this study. So this was a study of MSM that had been on PrEP, and that had a bacterial STI in the last 12 months. And they were randomized 2-to-1 to either receive DoxyPEP 24 to 72 hours post-sex or no PEP. And then those groups were randomized to receive the vaccine, the meninge-B vaccine, a 2-dose vaccine, or no vaccine. Key things that are different compared to the DoxyPEP study is that in the DoxyVac study, doxycycline was recommended only 3 times per week, whereas in DoxyPEP, it was permissible for people to take it every day if they needed to. So these are the data that was presented. So there was a a 14% had a 0.14 hazard ratio for chlamydia, so a significant reduction in chlamydia, as well as syphilis as well. You can see the numbers at the bottom. So consistent data with doxypep that this has high efficacy for chlamydia and for syphilis. And then there was a reduction in the time to first gonorrheal infection as well. And so there was in the interim analysis, it looked like this impact was larger than they had in this follow-up analysis, where the hazard ratio was 0.67. And when they looked at adherence, and this was quantifiable levels of doxycycline in plasma and urine, so these are not long-term like hair, that there was pretty high adherence. There was some doxypep use in the control arm, you can see in red, but that there was pretty good detectable levels of doxycycline across those who were prescribed doxypep. Unfortunately, it did look like there was no impact of the meningococcal vaccine at a p-value of 0.82. And so there didn't appear to be any impact of this vaccine on gonorrhea infection. I'm going to just skip through this quickly. There was no real evidence that it had any impact on any of the symptomatic or asymptomatic infections either. Moving from the research clinical trials into the clinic. So this was a study that we did in San Francisco that looked at Magnet Clinic, which is a large sexual health clinic in the Castro neighborhood. And we offered doxycycline PEP to all our PrEP clients starting in November of 2022. And we looked at an open cohort of all the PrEP users in a pre-doxy PEP period, offered them doxy PEP, and then looked at who started and who didn't start. And so among those who didn't start, we evaluated what the STI incidence was compared to those who did start over that time period. And what we saw was that about 39% of people started doxypep, and we wanted to see what the impact of that was on STIs in the clinic. It was dramatic and it was quick. And so among those who had started doxypep, STI incidence was 18% and dropped to 7.5%. And those who didn't start doxypep had a slight decline in STI incidence, but it was not statistically significant. Our hazard ratios, our risk reduction ratios are here. So overall about 58% reduction. So this is just offering it to everyone in the clinic. And this is what we saw in less than a year. We did not see an impact on gonorrhea. And so only 11% decline in gonorrhea infections compared to the pre-post analysis. So really something that I think we're going to have to keep monitoring closely, because we did see this in the doxypep and in the doxyvac studies. However, one of the original studies that was done in the ARNS in France and French-speaking Canada also initially didn't see a decline in gonorrhea, likely secondary to some resistance. When we looked at a different way to analyze this and see what the time, this is a interrupted time series analysis where we evaluated over time what happens to the slope of the decline. And in the blue line, you can see that that's the overall NESTI. And at the time we offered doxypep, we saw that the slope of the decline occurred and continued to go down. And we saw the similar patterns for all the STIs, for gonorrhea, chlamydia, and syphilis. And what's interesting is that we saw a decline in gonorrhea that was steeper when we offered doxypep, even though we didn't see an absolute reduction in the incidence. And so when we looked at those data a little bit more closely, we had actually been seeing an increase in gonorrhea. So the starting point may have been why we didn't see an absolute decline in our average incidence. So we're still looking at these data, but these were some of the first real-world data showing the impact of STI, of doxycycline on STI incidence. Our municipal STI clinic in San Francisco, City Clinic, also looked at their data and had a poster at Croy, which showed similar findings. So we have at least 2 clinics that are showing similar results for gonorrhea, for chlamydia, syphilis, but not for gonorrhea in San Francisco. And in San Francisco, because we rolled this out across the city, we were the first jurisdiction to recommend DoxyPEP for certain populations. We wanted to see what the impact was on our populations that we made recommendations for. So this was presented also at Croy, which shows the background incidence, background trends in STIs. And as you can see, there was a significant decline during the COVID period, but after DoxyPEP was offered, we looked at the time pre and post. So this is going to be a population level analysis of whether or not DoxyPEP decreased STIs in San Francisco as a whole. And so these were the results. So for chlamydia, monthly cases among MSM and transgender women declined about 6.6% per month after DoxyPEP was rolled out. So this is citywide. This is an ecological, so this is not a specific clinic that's being evaluated. But what you would see is a predicted level of chlamydia infections in blue versus what we saw in green. So about a 50% decrease in chlamydia infections in a year. So this is very, as I mentioned, this is very rapid and often very dramatic in our city. We saw a similar sort of trend for early syphilis. So what we predicted we should have seen versus what we saw after we implemented DoxyPEP, and about a 51% decrease. So these are also data that were presented at Croy. And we monitor through our Getting to Zero consortium the Sentinel clinics that are offering DoxyPEP. And so we have about 3,700 people who we know are on DoxyPEP. Is probably an underestimate because it doesn't include all the private providers who are offering doxycycline PEP for STI prevention. But we're seeing this at a citywide level now, where we had been seeing inclines and increases, and now we're seeing a 50% decrease. And then the similar theme for gonorrhea. So we had seen a sort of a decline in the pre-doxy period for gonorrhea. However, during the post-DoxyPEP period, we actually saw that the levels were higher, and these are significant. And so it's really not clear why this is occurring. We don't think that DoxyPEP is causing more gonorrheal infections, but I think that's something that we're going to be evaluating a little bit more over time. But I think that the sort of theme is the same. It works very well for chlamydia, works very well for syphilis. And in the clinical trials, it did appear to have efficacy for gonorrhea. I think in some of these real-world settings, it's calling into question the impact that this is going to have on gonorrhea. And then there was also another update of the data from cisgender women in doxycycline PEP. In Kenya, unfortunately, we had one trial that did not show efficacy for doxycycline for chlamydia, syphilis, or gonorrhea prevention. And this is likely secondary to low adherence. So these are the data that sort of showed that, and that it was very low. Only 30% of people had doxycycline levels in the hair, and that it was associated with older age, older being 24, and not having a primary partner. But there are hopefully follow-up trials that will give us more information on cisgender women, because we want to be able to, there's no real biological reason why we think this would not work for cisgender women, and so we want to have additional data and see if there's other strategies that we can use to support women in using DoxyPEP if that's their choice. So one of the questions that comes up is, what are the guidelines for DoxyPEP? And this is a slide courtesy of Stephanie Cohen, and they're all over the place. And so they are from not endorsing and reevaluating to the broadest, which I think are the California state guidelines, which are essentially anyone who wants it should get it. And the CDC draft guidelines, which are unclear when they're going to be finalized. There is a particular senator who wrote a letter to the CDC director calling into question some of the AMR concerns for doxycycline PEP. But they're sort of in the middle, sort of offering it to the individuals for whom they would have been eligible to enroll into a clinical trial like DoxyPEP. I think that in San Francisco and in California, we have erred on the side towards offering it more broadly. I think we're trying to take the lessons that we learned from the rollout of pre-exposure prophylaxis, all the risk and other criteria that we set in the beginning that we've now rolled back as we've seen how many problems that causes in implementation. And so I think that we are trying to use those lessons to roll this out in a way that's more equitable, provides access, and doesn't exacerbate disparities in STIs that already exist. So this is the preliminary CDC guidelines. And so this is the text around sort of being more permissive and considering it for MSM and transgender women who have not been diagnosed with an STI in the prior year. And so that is what our local guidelines in San Francisco and the California guidelines also support. And so we've sort of rolled this out to folks. And we are now actually offering it to cisgender women in our clinics. We've sort of taken an approach to shared decision-making to provide it to cisgender women. So we only have a few who are taking it, but you know, they've made those decisions with the data that we've provided them. So I'm going to spend a couple minutes on gonorrhea vaccines and open up to questions. So drug-resistant gonorrhea is an urgent threat that's been identified by CDC. And there are a couple of vaccines. This was data that was, this is before the DoxyVac study presented negative results for the gonorrhea vaccine. But it has the similar outer membrane structure that from N. meningitis that might provide coverage for N. gonorrhea, and that there have been some studies, including observational studies, that suggest that you might have some effectiveness in the 50% range for this vaccine in more observational. So there's a large study called MAGI, which is going to be looking at this, the Bexsero vaccine, to evaluate whether or not this might prevent gonorrhea infections. So this is an ongoing trial at multiple sites across the U.S. And in Thailand as well that are looking at trying to answer this question. I will say that in response to the DoxyVac study that showed a negative result, that the manufacturer is actually going back to try to build a outer membrane vaccine that's specific for gonorrhea, that's not cross-reactive with N. meningitis. And so we'll see if that sort of pathway goes forward as well. This is an ongoing study, the MAGI study, which is hopefully going to meet its enrollment criteria in the next few months. And then we might have some data. And so we'll be able to report those as they come out. So just in summary, before we move to question and answer, we've seen this continued increase in STIs, and particularly among syphilis, that we see that DoxyPEP has got high efficacy that's sustained in our clinical trials, that we're seeing it in real-world implementation, and that we're unclear how this is going to impact gonorrhea, and that we actually can see population-level impact in a very short amount of time. I don't know the last time we saw that type of population level impact seen in less than a year from an intervention that we've rolled out. And that we need options for cisgender women. I think that, that taking a daily pill for STI prevention might not be the most desirable for cisgender women for STI prevention in the studies, and that we might need some additional tools for gonorrhea prevention and hopefully a vaccine that might be available. So thank you for your attention, and I'm happy to take questions.
Thank you, Hyman. That was really terrific. I know there's tremendous excitement across the world to actually have some biomedical interventions to stem the tide of the bacterial STI epidemic that we're currently experiencing. So I'd like to invite you all, if you have questions for Dr. Scott, to come to the microphones here. We do have a couple of questions coming through on Slido. And again, if you want to handwrite questions, there are question card distributors in the audience. Hyman, let me start by asking, um, what are you doing in San Francisco with regards to offering the Bexsero meningitis B vaccine for gonorrhea prevention? Obviously, the UK has recently included it in their national guidelines, despite the data that is really vexing, and I'm wondering how you guys are approaching it, or if someone asked for it for that purpose, how are you responding?
So we are not really offering it sort of for that indication. It's hard to get in our jurisdiction. It's usually not covered by insurance. I know that there are some Kaiser providers who are offering it sort of more universally for their patients, but I think that the data are, questionable at this point about efficacy. So, not really pushing for that as an intervention given the data.
Great. So, question right here. Yes, please.
Hi, thank you. My name's Jason. I'm a nurse practitioner at Columbia, actually, here. A couple of questions. Have you had, excuse me, experience with folks who are maybe doing sex work who have multiple partners on a kind of more daily basis? Like, would there be recommendation kind of for, looking at maybe almost PrEP? Secondly, like on all these kind of ongoing studies, is there really kind of continued examination of MRSA and gonorrhea kind of resistance specifically? I know you're talking about like the microbiome and how there's kind of expression of those genes. And I really find that concerning. And kind of full disclosure, I'm also a gay man on PrEP for a decade, and I'm not convinced enough to take it myself, doxy. So just kind of these concerns, having seen in practice so many patients that, they have azithromycin left over from something else and they'll take it when I got a little cold or I feel a little burning or something. So that all those things kind of really concern me. So I'm just wondering like how much more ongoing study of specifically resistance is happening, and then particularly in the case of people who have maybe almost daily usage of it.
Yeah, so we definitely have people who use it daily. I think a lot of the data that we have for adherence, it doesn't really, like whether we're talking about PrEP or we're talking about hypertension meds, like we know that people are not gonna have perfect adherence. And so our approach has been to follow what was done in DoxyPEP study and allow individuals to take it daily if they need to. I think most people decide whether or not they want to do that, but also letting them know that there is some forgiveness if they want to sort of space it out. So some people do get GI symptoms from taking it, and so don't want to take it every day and can spread it out, but they can take it every day if they want to. And then your second question about microbial resistance, I think that we have the data from these studies, but we also have other data that we looked at with doxycycline used for acne, for other indications, and the idea that there's going to be resistance, to me, is not a question. I think that there's going to be some developmental resistance. The question is, how much is that going to impact the things that we care about? And is there going to be a clinical indication to analyzing these genetic resistance mutations? Does it change what we can use for treatments? Versus, can you see a 50% reduction in the cases of chlamydia and syphilis in your community in less than a year? So I think it's a pro and con, and each individual will make their own decision about it, and then how they want to use it. There will definitely be some sort of use of antibiotics for other reasons. Whenever we survey individuals and they have antibiotics, they use them for those reasons. I think they're sharing as well. Like, we have people who share with their friends, and we sort of address that directly. Say, we really want you to use this, and we want if you have people in your networks that need STI prevention support, we would rather see them to test them. But if you were to share this, recommend that they come in and get tested as well. I think what we're seeing mostly is that people are sharing it around group sex. So when there are orgies or sex parties that their friends are going to, and they don't have doxycycline, then they give it to them. I think some of the coordinators of those parties are also like having bowls of doxycycline available for people to take, which I think is,
That's a little scary.
What's that?
That's a little scary to me.
I think it's helpful. I think that if someone has an exposure and takes 200 milligrams of doxypep, and then if they come in and get tested, I actually think that might be a net benefit. And so I think we should rethink some of the ways that we approach this. I don't think that it's all bad. I think it's not something that we would recommend for sure. But the community is coming up with strategies to try to support sexual health and STI prevention. And so I think it's an opportunity for us to embrace and work with that, to try to identify strategies that we can help people get the testing that they need, and help people stay connected to care and get linked into care, make sure that people are on PrEP if they're interested and indicated, if they're on treatment, that they have support for adherence. There's a variety of things that we could just wrap around that. The community is responding in that way. I think we should try to work with that instead of chastising and not allowing that to be part of the conversation, because it's going to happen anyway. And so I think that our approach has been to be supportive of those in ways that we can, to try to support the STI prevention that people want.
No, thank you. We've got a whole bunch of questions, people chiming in electronically.
Okay.
So if you have someone who's interested in DoxyPEP for STI prevention, but they're not interested in taking HIV PrEP, how do you approach that situation?
I think what we try to do is I would give them DoxyPEP, and then I would continue to have the conversation. So if one of the expectations of DoxyPEP is regular testing, so you will also have the opportunity for them to come in more frequently and have those options. And then I would also, try to explore what is about HIV PrEP that's not appealing. It might be an oral pill. It might be the opportunity to talk about CAB-LA as an option for HIV PrEP, and then opportunities to check in. I think what we've seen is that oftentimes people's desires for these interventions shift over time, and so as long as they're connected to you, you have an opportunity to engage them more longitudinally about their prevention for both HIV and STIs.
Great. A bunch of questions about syphilis, and obviously exciting and impressive results for prevention for DoxyPEP in the context of early syphilis. Comments on both interpretation of RPRs in the context of DoxyPEP failure and incident syphilis, and whether those are more difficult to interpret and how you approach that, and also what your crystal ball says about what you think, if generalized to include cisgender women or even men who have sex with women, what the effects might be on the epidemic of congenital syphilis.
Yeah, so we definitely would expect that if someone, particularly is on doxycycline daily and has a syphilis infection, that the RPR will probably be lower than what you might have expected if they were not on DoxyPEP. And so what we do is we try, and I think what we're also going to have is people coming in every 3 months. So there was a really great presentation at CROI about syphilis, interpretation of RPRs in the setting of doxycycline PEP. And so you will likely have like a partially treated syphilis infection if someone is on DoxyPEP. So we have, if we see a twofold increase in an RPR with someone who has particular risk, particularly if they have an exposure, so if they're epicontact to someone diagnosed with syphilis and they have a twofold increase, we might either treat them earlier than we would have if they didn't. So instead of a fourfold increase, we might treat them for a twofold increase, or bring them back very quickly to try to repeat the titers to see if it's increasing. And I think what we have seen also is that we are using doxycycline for syphilis treatment now that we have this bicillin shortage. And so it's also an opportunity to potentially extend out, and just do a course of doxycycline instead of giving them a bicillin shot in those cases, so that potentially is exposing them to more doxycycline. But I think talking to people, they really don't like the bicillin shots. So if they are on doxycycline, have that as an option, they might they might be able to use that. And then we're preventing, I didn't show the data from the San Francisco City Clinic, but, they saw a 90% reduction in syphilis cases. So, we might just be preventing so many cases that, even if we make interpretation of these, it's going to be a much smaller number of cases. And then
So we are going to have to move on. I
Okay.
encourage people whose questions didn't get to be answered to find Dr. Scott at the break, and we can answer those. Last comment, Hyman, experience on C. diff risk and experience in transmasculine populations. Brief.
Not concerned about C. diff risk. We haven't really seen that. And we are offering and providing it to transmass populations. And we've seen about 25% of our PrEP cohort who are transmass take DoxyPEP. And we've seen similar reductions in STIs that we've seen with our individuals assigned male at birth.
Great. Thank you so much, Dr. Scott. That was really terrific. And again, apologies to those of you that we didn't get to your questions. Dr. Scott will be available at the break, so you can find him then. We're going to move